So we'll continue through all four of you, and then we'll pick up on some of these themes. So Rachel?
Great. Thank you, Bridget, and thanks to the forum leaders for the invitation. I came to NCDs quite a long time ago now, I guess. I think I'm probably one of the elder statespersons in a way. And similar to what Jean said, when I got into global health, there was a lot going on and a lot of really good people doing good things, but not apparently in the area of non-communicable diseases. And as an economist, my perspective is very narrow, very pointy-headed. It's how are we spending resources? Are we spending them in ways that address the problems that people are facing and living with? And it was obvious that increasingly in low and middle income countries, people are living with NCDs, but they didn't have anywhere to go. And often they weren't even aware of it or diagnosed. I think we all know that. And that captured my attention because I thought, okay, this seems to be a big problem. And obviously it's gotten bigger, as we've already heard this morning. And in order to bring some action, we need to speak to decision makers. And, you know, if there's one thing that decision makers are interested in almost everywhere and always, it's how much is it going to cost me, or what am I going to get if I do this, that, or the other thing? Will it be worth it? So in health economics, we're often trying to address the questions of value for money and, you know, how to improve on that. To me, it was more than just that. I mean, that's the pointy-headed, you know, pencil down part of it, and I certainly enjoy that. But, you know, again, like Jean, you know, what compelled me to try to work in this area that really there wasn't a whole lot of work, a whole lot of evidence, a whole lot of good data, and certainly not money, was this is being ignored. This is something that we really need to have more attention to. And so I do kind of like to work on the margins. Now it's a much bigger field, which is good. We've made a lot of progress in the past 10 or 15 years. And I'm speaking from a sort of a global policy economics perspective. I don't work in the field, especially. For years, really, my contribution has been to try to analyze the economic aspects. And again, you know, what really drew me to it and where I felt I could make a contribution was, you know, what are the economic implications of non-communicable diseases? What are the productivity impacts? What are the impoverishment impacts and so on? So that's really been quite interesting, and we have much better evidence on those things than we did 10 or 15 years ago. I can say with clarity, certainty, and numbers that it's costing this much, that it impoverishes this many people, that they don't have access to medicines means here's what's going to happen in terms of progression of disease and their productivity and so on. We do a lot of those kinds of studies. Now, what got very interesting, I don't really remember when I sort of got clued into the idea of integration. I think Miriam Rabkin was highly responsible. And it was quite fascinating because after sort of beating my head against the wall for a while, and other people were doing the same to try to draw attention and resources to NCD needs in low and middle income countries. And it wasn't really happening much. It became apparent that we had to think differently about, you know, it's not going to be a new vertical program. It's not going to be a new global fund. I mean, that was the mantra, still is the mantra all around. So what kind of options are there? And not only, you know, sort of as a long distance pass, but as maybe an efficiency measure. You know, actually, could it be a very good thing to figure out how to better integrate care so it's more patient-centered, so it's perhaps more community-based, et cetera. So, you know, those are things we'll talk about, I think, more through the rest of the day. But the thing, you know, we wanted to do some work on integration. We've done a little bit of work. I'll give my concrete example from a paper that we published, I don't even remember, Miriam, whether it was a year ago or 2 years ago, in a special supplement of AIDS, which was on integration, led by Waf El-Fazi and Eric Gooseby. So we were asked to do the economics paper, and to sort of cut right to the bottom line, there's very little evidence. We found 9 studies, 11 data sets that we could look at for costs and cost effectiveness of integration, all of them from Africa, all of them screening, not treatment management. And the assumption is often made, and I think that may be an assumption that people in the room have, some people in the room have, that this is going to be cost savings, or it's going to be at least cost effective to integrate screening, treatment care. And we were looking just at HIV and NCDs in that supplement. So there's obviously a whole world of other kinds of integration that can be done where there is more literature. But looking just at HIV and NCDs, we were not able to find examples where it's cost savings or even cost effective, with a couple exceptions. So cervical cancer screening, depending on how it was done in the context of HIV, looked like it could be cost effective. But again, individual studies in individual places with relatively small study populations, nothing at scale. So that sort of, I'll tell you I guess the additional cost that was identified in most of the studies that we looked at ranged from 6 to 30% additional cost of bringing NCDs into the HIV platform, to be very specific about the results. And you can all look up the study. In addition to looking at the quantitative data, and this was a review, we did a number of interviews. And interviews with people who work at the global policy level, donors, and people in country working on programs, implementing programs. Again, HIV programs where they were trying to integrate NCDs into the program. And almost all of the interviewees thought that it would be cost effective or cost savings to integrate NCDs. These are populations where there was a need for NCD care, where there had been identified burden of heart disease or stroke or potentially cancer. And so they went into it with the assumption that the economics would be a good argument for integrating, and yet they didn't have that evidence. So I guess for me, this workshop and the discussions that we have elsewhere about integration stem from the responsibility I feel as an economist to show whether or not that assumption is right. Can it be cost effective? Under what conditions? And there's lots of questions, because still we don't have sort of the model of integration. We're never going to have the model of integration. We're going to have a number of models, and we're going to have a number of things that make sense and things that don't. And that's what I'm really interested in finding out. So finally, just in the paper that we published, and I think this may be one of the later questions, what would we suggest? We, at least as from our pointy-headed place where we sit, we suggest that when you're doing integration, if you're doing integration, that you collect a minimum economic data set, which we can tell you what that is. We can help you collect it if you need, and that will help answer the questions that sort of drove me to this discussion, and I think it's a very worthwhile discussion, but I would suggest that we need to hold back those assumptions. Otherwise, we're going to be wasting money, and there's been already a lot of that in different areas of health. We can't afford it.
Thank you, Rachel.